If your mom or dad has just been diagnosed with mild cognitive impairment, or MCI, or mild dementia due to Alzheimer's, and you're weighing whether one of the newer drugs, Leqembi or Kisunla, might be right for them, there's a good chance you've run into the part that makes your stomach drop. The risk of ARIA, or brain swelling and bleeding. And chances are, your gut reaction was probably, this is not worth it. And I get it. That phrase, brain swelling and bleeding, sounds terrifying. But here's the thing. ARIA exists on a spectrum. The most severe outcome you may be picturing is actually pretty rare. So serious symptomatic ARIA occurs in fewer than 1% of treated patients. And most cases of what was detected in the trials, in the drug trials, were asymptomatic or mild. So before we can weigh the risks against the potential benefits we talked about in the last episode, let's look at the ARIA spectrum, what the headline percentages really mean, and who appears to be at higher risk. Well, hi there, Amy here. Thank you so much for joining me today, and welcome back to another episode of Happy and Healthy with Amy. So in the last episode, part 1 of this 3-part series, I asked the question, do Leqembi and Kisunla actually work? Does removing amyloid, one of the 2 hallmark proteins of Alzheimer's, make a difference? And the short answer is yes. These drugs do modestly slow decline. And the strongest signals that this is happening appear in people treated very early, particularly those with lower tau burden. So tau being the other protein, the other hallmark protein. So today in part 2, we're setting the benefit question aside and looking at the other half of the equation, the risks. And specifically, a side effect called ARIA, which stands for amyloid-related imaging abnormalities, what's seen on an MRI or magnetic resonance imaging scan. Okay, and for those of you who are new to this podcast or this series, this episode exists because I watched Dr. Armin Magamian's interview on Bright Focus Foundation's Let's Talk Alzheimer's podcast, which is hosted by Nancy Keach. So in part 1, we broke down what he said and what the pivotal human trials tell us about whether these drugs actually work, what's referred to as efficacy. Today, we're going to break down what he said about risk. And just like the efficacy data in his interview, it came pretty fast with a lot of clinical terminology. So if you'd like to watch the interview, I've put the link to that episode in the show notes. And if you're watching on YouTube, you'll find it in the first comment. All right. And by the way, I think he really did do a great job of explaining it. But he covered a lot of ground pretty quickly. So if you're new to the Alzheimer's world and hearing about all of this for the first time, it could easily feel like you're trying to drink from a fire hose. And his interview could leave you more alarmed than informed. Okay, that's why I decided to record this episode. I'm going to take my time going through the risks. Okay, and this entire episode is dedicated to just the risks. Again, we covered the benefits in the last episode. I don't know which way to go. So if you have questions but haven't seen that episode, you may want to pause this one and watch that one first. Okay, and then in part 3, in the next episode, I'm going to walk you through a decision-making framework. Okay, questions to ask the neurologist, and other factors also worth considering. But today, this episode is just about understanding the risks, especially ARIA, okay? What it actually is, how serious it can be, why it happens, who seems to be at higher risk, and how doctors watch for it. And as always, this is education, not medical advice. Okay, so please make sure you're working with a licensed healthcare professional for any actual diagnosis or treatment decisions for yourself and or your loved one. Okay, so now let's get into it. First, I want to separate two things that get lumped together in people's minds. Because if you don't know the difference, you might end up thinking every headache or wave of nausea after an infusion of one of these medications means something catastrophic is happening in the brain. And it doesn't. Okay, so to understand the difference, you need a quick primer on what the drugs do. So both Leqembi, or lecanemab, and Kisunla, or donanemab, are monoclonal antibodies. That's what the mab ending traditionally stands for, right? MAB. So donanemab is given by IV infusion, while lecanemab can now be given either by IV or by a weekly under-the-skin injection. So these treatments deliver antibodies that then bind to amyloid in the brain and recruit the immune system to help clear it. Okay, so when a monoclonal antibody is introduced into the body, it can trigger a temporary systemic immune response. These are called infusion-related reactions. And most of these are mild. Okay, we're talking things like chills, fever, body aches, nausea, or headache. And then less commonly, people can develop chest discomfort, trouble breathing, or significant blood pressure changes, which do require closer monitoring because they can signal a more substantial infusion reaction, or in rare cases, a serious allergic reaction. Okay, so these reactions usually occur either during or shortly after the infusion, and they tend to cluster in the first few doses. So in Clarity AD, this is the name of the lecanemab trial, infusion-related reactions occurred in about 26% of people receiving lecanemab. Okay, with donanemab, the rates have been varied by the dosing regimen, as in how much they were given. And in the newer gradual titration study, where they're increasing the dosage at a slower rate, okay, they occurred in roughly 16%. So this is one reason patients receiving the IV formulations are monitored during and around the infusion. Now, with the newer under-the-skin form of Leqembi, treatment can eventually be given at home after the patient or caregiver has been trained under healthcare provider guidance. So these side effects are thought to come mainly from your body's immune system reacting to getting an antibody, right? It's uncomfortable, but it's what's called a systemic reaction, meaning it's happening throughout your body, right? Not something specific to the brain. ARIA is different. It's a brain-specific vascular complication, meaning it's about what's happening to the blood vessels in the brain, okay? And here's the tricky part. Headaches, dizziness, and nausea, right? These can show up with either one. So symptoms alone can't reliably tell you which one you're dealing with. And that's exactly why timing, a full neurological check, and imaging matter so much. So we're going to get to all of these in a few minutes. But first, let's talk about what ARIA is. So ARIA, again, stands for amyloid-related imaging abnormalities. Note that word imaging, okay? A lot of ARIA is found because a patient goes in for a scheduled MRI, and not because they feel anything unusual, okay? There are two types of ARIA. ARIA-E, where the E stands for edema, means that fluid has leaked into or around brain tissue and causing swelling. And then ARIA-H, where the H stands for hemorrhage, means bleeding. Now, here's one of the key takeaways I want you to get from this episode. ARIA exists on a spectrum, from asymptomatic MRI findings to rarely serious neurologic complications. Okay, for example, ARIA-H includes tiny areas of bleeding, what Dr. Magamian called small microbleeds, or blood breakdown products that show that bleeding has occurred. Okay, and these can be visible on an MRI even when the patient has zero symptoms. Okay, so the concern is that these microbleeds can become a larger hemorrhage, particularly in someone whose brain blood vessels are already vulnerable. And as I noted in the opening, chances are your mind automatically went to that severe end of the spectrum, where someone has a major brain bleed or seizure or permanent injury or even dies, right? Those outcomes can happen, and I'm not trying to minimize them. At the same time, it's important to note, serious symptomatic ARIA is rare. Okay, Dr. Magamian put it at less than 1% of patients treated with these amyloid targeting therapies. Okay, so now let's actually review that spectrum. Level 1, we're talking MRI-only ARIA. So no symptoms at all, asymptomatic, found on a scheduled MRI. And this might be mild enough that a doctor just monitors it or briefly pauses treatment. Okay, Dr. Magamian noted in the trials, roughly 75% of people who developed ARIA are asymptomatic, are in this category. Okay, 75%. Level 2, MRI confirmed ARIA with mild symptoms. So this is headaches, mild dizziness, nausea, maybe some mild confusion. Okay, and here's an important nuance. Having one of these symptoms doesn't prove you have ARIA. Okay, it's the MRI that establishes whether ARIA is present. And these are usually temporary and resolve as the swelling subsides over days or sometimes weeks. Okay, then level 3, clinically significant symptomatic ARIA. This is definitely more serious. Substantial confusion, difficulty walking, maybe some vision changes, trouble speaking, weakness on one side of the body, or seizure. So some significant neurologic symptoms resolve as the ARIA resolves. But these cases do warrant urgent medical evaluation and can require hospitalization and more intensive treatment. Okay, and then level 4, severe ARIA or major hemorrhage. So this is rare, but it can involve severe brain swelling, a major hemorrhage, seizures, and in the rarest cases, permanent injury or death. So when you hear a top line number of X% developing ARIA, I want you to remember that this whole spectrum sits underneath that one number. Okay, most ARIA cases detected in the trials were again asymptomatic or mild. And while serious cases do occur, right, and I'm not going to minimize that, they are still the minority within the minority. So Dr. Magamian put serious symptomatic ARIA, again, at less than 1% of treated patients overall. Okay, so what are the actual numbers? In Clarity AD, again, this is the lecanemab trial, ARIA-E occurred in 12.6% of treated participants and ARIA-H in 17.3% of treated participants. In Trailblazer, ALS 2, okay, this is the donanemab trial, ARIA-E occurred in 24% and ARIA-H in 31.4% of treated participants. Okay, and then it's important to note that since that pivotal trial, okay, donanemab has moved to a newer, more gradual titration schedule, meaning the dose is increased more slowly than it was in the original trial. Okay, that original regimen. And then in this later study, that gradual titration actually reduced ARIA-E to about 16%. So yes, that's a lot of numbers. And I think it would be easy to hear 12.6% versus 24% and conclude that lecanemab is roughly half as risky as donanemab. Okay, but remember, donanemab's dosing strategy has since changed specifically to reduce ARIA-E. So we don't have a clean head-to-head comparison that tells us one drug is simply half as risky as the other. Again, also remember, right, the percentage of patients with actual symptomatic ARIA was much, much lower than that total MRI detected rate I just gave you, right? Most of what's captured in those numbers never produced a symptom at all. All right, so why does this happen in the first place? This is where something called CAA comes in. It stands for Cerebral Amyloid Angiopathy. Okay, cerebral meaning brain, amyloid, the protein, and angiopathy meaning diseased blood vessels. So amyloid doesn't just build up as plaques in brain tissue, okay? It can also build up in the walls of the brain blood vessels. And when that happens, those vessels get more fragile. Okay, so here's the leading explanation for ARIA. And I say leading explanation because there isn't one fully proven mechanism yet. So this is our best current understanding. Okay, amyloid deposits in the blood vessel walls. Those blood vessels become more fragile. Then anti-amyloid therapy comes in and mobilizes amyloid, right? Meaning it starts moving and clearing it. And then during that process, the blood vessel walls can temporarily become more permeable, right? Allowing fluid or small amounts of blood to escape. That's what can show up as either ARIA-E or ARIA-H. Okay, and then two more terms worth knowing. A microhemorrhage is a tiny area where blood has leaked into brain tissue. And it often leaves behind a substance called hemosiderin that shows up on an MRI. And then the last one, superficial siderosis, is when blood leaks near the surface of the brain, breaks down, and then leaves iron-containing hemosiderin along that surface. So you can think of it like a rust stain left behind after a tiny leak. Okay, and I want to be clear, superficial siderosis usually tells a doctor that bleeding happened previously. It doesn't necessarily mean active bleeding is happening right now. Okay, and doctors care about this because it can be a sign of underlying CAA and vascular fragility. Okay, now quick tangent because it may help further explain the different ARIA rates. So amyloid plaques form over time, right? And as they do, they go through different stages. So lecanemab tends to target an earlier form of amyloid called protofibrils, whereas donanemab targets a different form called pyroglutamate amyloid. Okay, these are found in fully formed plaques, like more mature. So ARIA risk seems to depend on what form of amyloid is being targeted, along with how strongly the drug engages with amyloid in and around blood vessels, and then how quickly amyloid gets cleared. So I don't think it's accurate to say donanemab caused more ARIA in the trial because it attacks mature plaques. That's oversimplified, okay? But I do think its strong engagement with deposited plaques and how fast it can clear amyloid may contribute to the higher ARIA rate that happened during the trial. And case in point, right, slowing down the dosage increase, that titration reduced ARIA rates, even though the antibody itself didn't change at all. So again, how quickly amyloid gets mobilized seems to matter, not just which antibody is used. Okay, now let's shift from the science of why this happens to who seems to be at higher risk for it. So first thing to consider is a gene called ApoE, apolipoprotein E, specifically a version of it called epsilon 4, right? What's commonly referred to as ApoE4. So if you have no copies of ApoE4, your risk is generally lower, okay? 1 copy, your risk is medium. And then 2 copies, it's higher. And it's not linear, it's a much bigger jump. Okay, and this matters especially for symptomatic and severe ARIA. Second, what a baseline MRI shows before treatment even starts. So the neurologist is looking for existing microhemorrhages, right? That superficial siderosis I was talking about, those rust stains, or other signs suggesting CAA is already present. Okay, and then third, anticoagulants, right? We're talking about blood thinners here. Medications like rivaroxaban, warfarin, and similar drugs. So these medications can complicate the bleeding risk calculation. But that's not the same thing as saying someone on a blood thinner can't take these drugs, okay? It's an individualized conversation between a patient, their neurologist, and often their cardiologist, because there may be some options besides anticoagulants, right? And then one more thing, ARIA can actually mimic a stroke. Let me say that again. ARIA can mimic a stroke. So if someone on anti-amyloid therapy shows up with sudden neurological symptoms, it's critical that the treating team knows they're on one of these drugs. Because if those symptoms are actually being caused by ARIA, particularly ARIA-H, a clot-busting medication could be dangerous. And finally, these aren't the only medical considerations, right? A neurologist also reviews someone's overall health, other medications, other neurological conditions, and whether ongoing MRI surveillance can even be done safely for that person. Which brings us to the surveillance MRIs. And because ARIA happens disproportionately early in treatment, if you look at the schedule, you'll see that the monitoring schedule is front-loaded, okay? There's a baseline MRI before treatment even starts, right? This is to establish whether there's any pre-existing vascular abnormalities, right? The CAA we were just talking about. Then early treatment MRIs, because that's when ARIA is most likely to show up if it happens. And then symptom-triggered MRIs, meaning if someone develops a new headache or has some confusion or is experiencing vision changes or trouble walking or weakness or having seizures, right? That will prompt additional imaging right away. So I want you to think of this monitoring schedule as more than just watching for a catastrophic event, right? It's designed to catch ARIA early so it can be identified and managed before symptoms develop, or the imaging abnormality potentially worsens. And when ARIA is found, what happens next really depends on the imaging severity, right? Whether or not the person has symptoms and what those symptoms are, whether it's progressing, and that person's overall medical picture. So depending on all of that, the response might be to simply monitor it, or temporarily hold off treatment, or repeat the MRI and then restart treatment later, right? Or permanently discontinue it. And of course, in a severe case, hospitalize and treat it directly. Okay, so here is the big takeaway from today. In part 1, we talked about how the potential benefit of these drugs isn't identical for every eligible patient, right? Same is true of the risk. So the headline ARIA percentage is not the same thing as your loved one's individual risk. Okay, so now we've got both sides of the equation. Part 1, we looked at who appears most likely to benefit. And today, we looked at what makes treatment riskier. And in part 3, in next week's episode, we're going to put these pieces together, okay? I'm not going to tell you what your mom or your dad or another loved one should do, but we're going to go through a framework for the conversation with the neurologist, right? And then one more thing before I wrap this up. These drugs are not the entire treatment plan. Okay, Dr. Magamian actually interrupted Nancy Keach near the end of his interview to make this point. And that is, Alzheimer's is a multi-pronged disease. So we want to be multi-pronged in our approach, meaning managing vascular risk, like high blood pressure or high cholesterol, staying physically active, eating well, right? Remaining socially and cognitively engaged, and addressing the other factors we know influence brain health. These still matter. Now, if your mom or dad or you has just been diagnosed, I want to make sure you're aware of my first steps guide. So it's the 8 things I wish my family and I knew about when my mom was first diagnosed in 2016. Okay, and it'll help you move forward with more calm, clarity, and confidence. So I've provided the link in the show notes and description. And if you're watching this on YouTube, here's the QR code. Okay, and then to Dr. Magamian's point, if you're wondering about what lifestyle factors can positively influence your brain health, you'll want to download the Restored Protocol. Okay, this is my free brain health guide. It's also linked below, and here's the QR code for those watching on YouTube. Okay, and then finally, I do have a favor to ask. If you learned something today, if this video helped you, okay, please like it, subscribe, comment, and let me know what made the most impact, and share it with someone else who could benefit. Because the Alzheimer's journey is a difficult one. But you don't have to navigate it alone. Okay, let's support each other. Alrighty, so I'm going to wrap things up today with a quote by Marcus Tullius Cicero. Prudence is the knowledge of things to be sought and those to be shunned.